To hear the full episode, become a patron at patreon.com/deathpanelpod.
Welcome to the Death Panel. Patrons, thank you so much for supporting the show. None of the work that we do would be possible without you. To become a supporter of the show and get access to the second weekly bonus episode, as well as the entire back catalog of bonus episodes, become a patron at patreon.com/deathpanelpod. And to help us out some more, share the show with your friends, post about your favorite episodes, pick up copies of Health Communism, A Short History of Transmisogyny, and Abolish Rent at your local bookstore, or request them at your local library, and follow us at deathpanel_. I'm Beatrice Adler-Bolton, and today I'm joined by my co-hosts, Artie Vierkant.
Hello.
And Phil Rocco.
Hey.
And just a note at the top that by necessity, Baby Death Panel is joining us for this recording today, so apologies in advance if there are any adorable baby noises that make it into the final edit of the episode.
No apologies in advance.
So in today's episode, we're going to discuss the healthcare provisions of the GOP's so-called Big Beautiful Bill, which has been aptly nicknamed the Murder Bill. The three of us are going to walk through the material changes that this legislation is going to impose. It's a sweeping, calculated slashing of federal support for various health programs that siphons funds from community health centers and rural hospitals. It imposes work requirements and will result in lost or unaffordable coverage for tens of millions of people in the immediate term and over the coming years. We'll start with what's in the bill, why it matters, and how it's already destabilizing the healthcare system. Hospitals are already closing or actively considering doing so, cutting programs and laying off staff. Over 330 rural hospitals are at risk of closing. 5 states have planned special legislative sessions to figure out how to handle work requirements and slash their already enacted Medicaid budgets. And even though the provisions of the murder bill don't all start immediately, states and providers are making cuts now in anticipation of future revenue shortfalls and future increases of uncompensated care and lower payment rates. Finally, we'll talk about what Democrats are doing in response or not doing, and discuss whether this moment offers a real political opportunity or just another chance for Beltway liberals to fundraise while they lose out strategically by limiting political will and imagination.
Well, I think I know which one they would choose if they had their druthers, but yeah, I mean, Phil, we were talking about this last week, and you said something to the effect of, this is probably one of, if not the single biggest welfare retrenchment really in history. I was wondering if you would want to expand on that, because I think that's just a point that I have not seen made.
Well, I mean, if you look at like the history of the American welfare state, one of the, I think, kind of conventional wisdoms is that, like, yes, the welfare state kind of gets cut back from time to time in stealthy ways. There have long been conservative strategies. In the early 1990s, there was something that conservatives refer to as their Leninist strategy for getting rid of Social Security. But with the exception of a program called Aid to Families with Dependent Children, which was essentially cash support for mothers in the 1990s, which was a very targeted program. It was a program that had been kind of under assault for decades, and that, Democrats had also made it a priority to like really gut as well during the apex of their neoliberal phase, although that apex seems to be kind of a long one.
More of a sine wave.
Right, a sine wave. I think the political science conventional wisdom was that all other programs were on a trajectory of like continuous growth, right? Medicare and Social Security, because they were universal, popular programs, and Medicaid, not because it was universal or, for years popular. I think it was frequently for decades, derided in the same way that welfare was derided. And there was an attempt to kind of link those two things together. But largely because Medicaid had all of these constituencies that were essentially, industrial or government constituencies, hospitals, healthcare systems, eventually managed care companies, insurers. Governors loved it because the design of the program gave them the ability to deliver a big benefit and a boost to their economies without having to raise taxes a lot. So Medicaid was also on this trajectory of kind of unparalleled growth. And as employer insurance became increasingly unsustainable as a model for a variety of reasons that we've gone on, see any number of episodes we've done on the history of health insurance in the United States, like Medicaid just became the way of like backfilling the gaps in the system. And so I think by the time the ACA passed, people kind of thought that it was like, almost like if not Teflon, then really, really hard to claw back in this kind of direct way. And so
Right.
like tons of people, like New York Times columnists and other kind of political scientists, they're like, well, this is not necessarily, I don't think people saw that it was going to be this big, because it's from the Medicaid part of the law alone, it's 12 million people kicked off of the program. And the way we can talk about like the way that that's going to happen, but just in like numerical terms, there's never been that kind of deliberate effort to take something where it's like there's been like a new set point and we are going to deliberately claw it back. And we could talk about, the unwinding as, another kind of big moment where there was a new set point reached. Although, I mean, this is taking a huge chunk of the law, and not just the work requirements piece of it, but also the way that it's changing the tax structure of the law and really like fundamentally changing it in this ways. Now, what the ultimate trajectory is going to be and how it's going to shake out is unclear. But I think that the point is, I think for years, people thought that Republicans couldn't find a sort of political formula for gutting Medicaid, and they found one. And
Right.
the question that I find fascinating is kind of, there's just a lot of like staring at the abyss in like an analysis right now in like major news publications and even more specialty like political magazines. I think it really, I don't know, maybe we're not even a month out. So people are still just sort of like staring at the abyss. But I think a lot of people did not expect this to happen in quite this way. And we need to sort of grapple with like, what were the political factors that made that the case? And like, I think that there's just this still sort of inbuilt sense, like, well, this is going to be really unpopular and Republicans are going to get punished for it and Democrats will come back to office and then we'll just sort of like reset. And like, I think there's a lot of, just to be, I guess, polite about it, it's just like, there's a lot of holes in that logic.
Yeah, and I think we'll get to those sort of broader political dynamics in a second, but I do think just from the top, I think it would be good to just talk about the scale of it a little bit.
Absolutely.
We did do a little bit of this also in the socialism conference panel that B and I did with Vicky Osterwile that's in the feed now, although always good to reiterate, especially because I know, live audio, I mean, never my favorite thing to listen to personally. But with this bill, when we talk about scale, we're talking about a full estimated $1 trillion being cut out of Medicaid. That's through a variety of somewhat wonky, but not actually terribly difficult, I suppose, to explain changes to funding mechanisms within Medicaid, and also due to estimates about the tightening of eligibility requirements, the addition of work requirements, things like that. Effectively, as I said in that socialism conference panel, though, this is, deliberately taking $1 trillion out of Medicaid, the healthcare program for the very poor, the program of last resort, and far and away the single most important provider of long-term care for disabled people in this country, kicking tens of millions of people off of that program, causing by one estimate 50 or 51,000 additional deaths per year just from creating new uninsured. So this bill has the same death burden as the average influenza season. And of course, it needs to be said also, not that these things are directly one-to-one, but taking that money, at least rhetorically, and funneling it into the expansion of ICE. And so that, I think, tells you, if what's the famous Kim Phillips Fine quote, right? All budgets are stories about the future.
Yes, exactly.
This is, a very, very explicit and very dire story about the future that this bill is telling. But also we have in this some top line changes, the addition of work requirements. So people who are between the ages of 19 and 64 who qualify for Medicaid will now need to work, quote unquote, participating qualifying activities, which is a job or certain types of volunteer work for at least 80 hours per month. The hard part of that, of course, is going to be, as we've talked about on the show before, obviously, so many people, most people who can work, who are on Medicaid already work. That's, a point that even, liberals will repeat ad nauseum about this, but that's sort of not even the point. The point is largely that then, each state is going to create their own paperwork requirements for how this is done. It's going to add this onerous burden. And then on top of another provision in the bill, the addition of coverage redeterminations every 6 months, as opposed to every year, which had previously been done, is going to just kick so many people off the program simply for procedural reasons. It's tightening the screws essentially on a system that is already designed for what is called, quote unquote, churn in this kind of way that the policy discussion tends to give things these sort of
defenses of the indefensible, right?
Right. And then in terms of the systemic effects, without sort of getting into the funding mechanism changes in this short description, I think it would be good to at least mention some of the effects that have already begun to happen and already begun to show. This is, I think, best illustrated really in this, frankly, very good piece from the American Prospect, which this is such a good rundown. I feel like I just need to kind of point to this and read a little bit of it. So this was from July 15th from the American Prospect, called GOP Wrecking Ball Slams Through Medical System. They note that, quote, the spending package also immediately barred Planned Parenthood from receiving any Medicaid funding, a change that the CBO expects won't save anything, but will actually end up costing $52 million. Multiple Planned Parenthood local websites have posted notices saying they still accept Medicaid, but some warn they are barred from accepting payments. A message on the Planned Parenthood of the Rocky Mountains website cautions that the spending bill blocks patients who are enrolled in Medicaid from receiving care at Planned Parenthood. This means if a patient is enrolled in Medicaid, they can no longer receive any services at our health centers, even if they are not paying for it through Medicaid. Continuing to say, Curtis Medical Center in Nebraska was the first to announce its closure, and more are considering doing the same, such as the Safety Net Hospital Lady of the Angels in Bogalusa, Louisiana. Sorry if I mispronounced that. Garnet Health in New York cited anticipated federal cuts as the reason it restructured last month, laying off 42 workers and cutting outpatient pulmonary rehabilitation from one location and outpatient diabetes services at 2. Northern Light Health in Maine has advised of imminent workforce and services reductions. Indiana's Columbus Regional Health did the same last month after it issued a warn notice announcing the layoff of 50 workers. And it sort of goes on like this. So this just shows that this is, I think it's one thing to talk about sort of coverage losses here. One thing I didn't give in this rundown already is the estimate that Phil mentioned earlier, which is it's estimated that from this bill, between 10 and 12 million people will lose Medicaid. You'll see a lot of people kind of throwing around the number 17 million people losing health insurance. That's from adding 5 million from people assuming that Republicans aren't going to expand ACA tax credits. But so, 10 to 12 million people expected to lose Medicaid. But I think what the reason that I bring up this reporting from the Prospect is that it would be kind of misleading to simply talk about the effects of this bill in terms of coverage losses. Because while that is obviously an incredibly important part of this and will have such dramatic negative consequences, this is also something that is, when you suck $1 trillion out of Medicaid, you're not just really sucking $1 trillion out of Medicaid, right? You are removing $1 trillion from the health system as a whole. And there are effects that come with that.
And there are 3 things I really just want to kind of drill down into and talk about in a little bit of detail. The first being around the work requirements issue, where we have this idea, right, of like everybody who is disabled must be certified as disabled,
right,
must have the burden of proof necessary to prove that they can get out of these work requirements. And that is absolutely not the case, and especially on Medicaid.
Yeah,
Medicaid is what supports people as they apply for SSDI and they wait to be officially certified, where, you have these long periods where you're expected to not work at all in order to prove that you qualify for Social Security disability insurance, where you're on Medicaid, but you're not officially certified as disabled until your SSDI application is approved, right? And then you can apply for SSI. And so you have this population that is certified as disabled on Medicaid, right? But then you have this huge other population that doesn't necessarily totally meet the definitions of disability that are used in order to exempt you from work requirements, for example. So you have this incredible cliff and crack that it's being created here, right? Where you have all of these people who are already dealing with the paperwork burdens of trying to apply to certify themselves as disabled, who don't officially count as disabled under these very narrow definitions, but
as far as the state sees it, yeah.
Right, but who are disabled, who are not able to work, who then have this additional paperwork burden, surveillance burden, and potentially punishment as a result of the work requirements that, this is like a doubling the administrative burdens that are on a population that is already under like extreme duress, right? The second thing I want to talk about layers onto this, right? Which is that, like, yes, funding is being taken out, but there are also things that are being imposed that are requiring additional funding to go into them. So work requirements can't just be implemented with the snap of a finger, right? Like, it requires setting up infrastructure in order to collect the information of people reporting, right? We have to set up these portals for each state where you're going to have people logging in to log their hours and certify that they've been doing their job search or that they've been working enough hours. And all of this is going to cost money. States don't have the expertise within their departments of Medicaid to, program these softwares. These are all contracts that are going to go out to management consulting firms, to tech firms, to IT companies, who are then going to be siphoning money off of these budgets that are being cut, right?
So, well, and the thing is, like, that's the right. Not having those systems, like, whether or not, like, I've seen one point. I think there was an article by like Jennifer Palka in the New York Times. It was like, saying, quote, strong state teams using AI well can reduce the effects, essentially the effects of work requirements. And it's like,
God,
that's, and it's funny. I've gotten that question from people. They're like, is there a way of like doing work requirements well? I'm like, the point of them is, but it's like, but the thing is, either there is some magical way that is, possible, or it has to be the case that the projections of how many people are going to lose their coverage were a lie, and it was only existed on paper to make like the numbers work for the bill for the tax cuts, right? But the point is, if you expect the bill to be implemented as written, the goal is to throw that many people off healthcare. Like,
right, exactly.
I find like one of the conventional wisdom, or one of like, I think that, I don't know, maybe it's like predictable responses that people have when they're surveying this is sort of, how do we mitigate the harm that's going to come from this? And, by all means, we should be doing whatever is possible, what in whatever capacity we have to ensure that people don't get thrown off of Medicaid, right? But imagining that state governments are going to be leading the way in doing that is, that you're living in a fantasy world. I think. Some states will probably do what they can to like soften the blow in some respect. But if you really think that the federal government is going to implement this law in the way that it's written, which I think there's good reason to believe, although they have some discretion to like selectively enforce it where they want to and where not, lots of people are going to lose coverage. There's no way of like sugarcoating or technologizing that.
Well, and it's not just the work requirements, it's also the 6-month redeterminations too, because
I forgot about that. Yes, that's the whole other thing we talk about is just work requirements. The 6-month redeterminations are a whole other layer of this that really, it's like the discussion about the legislation prior to its passage. It's as if work requirements were like the only thing in there, but the redeterminations are huge.
It's as if, the redeterminations and the work requirements like cost no money too, is the way that it's
yes, of course,
perceived in so many instances, right? So we have all this disinvestment from Medicaid, and I want to talk about like specifically how that's happening in a second. But then you have this like additional burden that's being placed on state Medicaid programs that are essentially requiring them to make investments, right, in contracts, right, with consulting firms. So this isn't just like a retrenchment of the welfare state, it's also an expansion of a market at the same time.
Absolutely.
And that, the fact that this is a vast market opportunity is often not portrayed as the top line. And I think that's incredibly important to center here, because contractor payouts are part of the point of this legislation, right? Like, not just the money coming out of health programs, but where money must be sent as a result of changes like the work requirements or the redeterminations.
Yeah, there's a reason that this bill has been called, I think the quote was welfare for Deloitte.
Yes,
absolutely. That's a good way of putting it.
Yes, absolutely. We're talking about people losing coverage, right? And really, what's the point of this loss of coverage is to pour money into private contractors. So I've gotten a lot of questions from people where they're like, oh, you've talked about this as being intended to usher in, opportunities for privatization, right? And like, how does that really work if you're kicking people off of health insurance? Does it work in the capacity of, people losing Medicaid and then having to sign up for ACA plans? And I'm like, no, that's actually not really what they're doing here, right? Like what they're doing is taking essentially a program that was intended for public provisioning of healthcare, and they're requiring a certain amount of those funds to be spent on the private provisioning of services. And you're actually taking Medicaid's remit as a state-funded healthcare provisioner, and you're saying actually the top line remit of this program and this funding isn't provisioning healthcare, it is managing and issuing these private contracts, right? And that I think is a little more complicated than understanding this as a kind of one-to-one translation of creating a customer flow, let's say, from Medicaid into private plans. It's not about the insurance plans at all. It's about where this public money is being spent and who is entitled to this public money. Is it Medicaid recipients, or is it private firms and contractors who will manage the software needed to police and surveil the recipients?
To hear the full episode, become a patron at patreon.com/deathpanelpod. You'll get access to this and the rest of our catalog of patron-only episodes, and be the first to get a new patron episode every Monday when it drops. With love, the Death Panel.